Cool, yeah, should we take it away?
Yeah,
Yeah.
go for it.
Cool. So welcome to our SBA quiz. So we're doing like a mix of stuff that has come up this term on our teaching. And so I'll hand over to Prina for the first one.
Okay, so you should be able to see the question.
Oh, press enter to start countdown. Should I just do it?
Yeah. Oh, I forgot that the timing on this is stressful.
Oh yeah, it's like 5, 4, 3, 2, 1. God, that's really stressful.
So 11 people answered, and and a lot of you got it right.
Fab. Okay, so this is quite a heavy slide, but I'm basically going to talk you through the different types of leg ulcers that you can have. So you can have arterial ones, you can have venous ones, and you can have neuropathic ones. So the venous ones are the most commonest, and they are basically due to venous insufficiency. So there's loads of different causes of venous insufficiency, and when we'll send out the slides, I put like quite a lot of information in the notes about it. But essentially, they're ones that are really they're like moderately painful, and they've got not the clearest margins, a bit sort of not very well structured. Sometimes they bleed a little, and the surrounding area can be a bit darker because there's like hemosiderin deposited. And the most common place that you can get it is like on the medial malleolus. Does someone want to put in the chat why they think or know why it's the medial malleolus? So what venous structure or what vein can you think of that's located near the medial malleolus? Okay, I'll rephrase. What vein? Yeah, okay, so which saphenous vein? There's a long and a short.
Oh, a good old 50-50.
Yeah, exactly, the long one. So basically, the long saphenous vein at the medial malleolus is where it has the highest hydrostatic pressure. So that's the point where if there's any venous disease occurring, it's most likely to sort of begin. And that's why the ulcer happens there most commonly. Okay, so moving on to the arterial ones, they're really painful and they're like quite punched out. They're due to sort of, in one form or another, ischemia essentially. Most commonly, it's due to atherosclerosis, and you find it sort of in the parts that are like the furthest away, so toes, extremities, like your heel, basically. And the way you can sort of confirm it is checking there's no sort of pulses nearby. That's a good indicator. The neuropathic ones are mostly seen in diabetics because they get neuropathy. And the sort of pathophysiology behind that is essentially if you can't feel pressure on your foot in places, you can't feel the ulcer happening, essentially. So these are painless. They won't or have very minimal pain, and they're at pressure points. So like your heel, the base of your toes. And yeah, so we're going to quickly just go through it in the chat. Now that I've explained that, number one, arterial, venous, or neuropathic, you can just put A, V, or N. You don't have to type it out. As in,
Unfortunately, no extra points for these.
Yeah.
Sad.
Okay, so what if I was to tell you this is somewhere like around the ankle on the shin? No, so this one's actually arterial, but good guess. It could be one or the other. So number one is arterial. And the way that you can think about it is like it's pretty much a perfect circle. Like it's got really well-defined boundaries. And that's that's like the main indicator in that one. If you compare that to number two, which I'm just going to tell you is Venus, it's kind of a really odd shape. You can't really even see the break in the skin that's beginning, and there's like a brown pigmentation behind it. So that's Venus, number two. Number three. Number three is Venus. Yep. Number four. Yep. So number three was Venus. Number four is neuropathic. Perfect. Yeah. So if you look at it, it's like on the base of their toes, so kind of where you would have a like pressure from the arch of your foot. And it's yeah, so that's the neuropathic one. And number five, finally. Nope. So number five is arterial. Yeah, it's like it looks literally punched out, and it's again a perfect circle. And if you look at the skin around it, that doesn't look like there's any sort of depigmentation, any venous insufficiency occurring there. Okay, so if we just go back to the question, sorry, Izzy.
Yeah, one sec.
So in the photo, which we can't see, the ulcer was a neuropathic one. It was like on the base of their foot. It was neuropathic. So the most common cause of that I wanted you to pick up was diabetes, and hence the investigation you'd want to do to check that is a HbA1c. The home blood pressure monitoring you do for hypertension, if you thought, is this arterial disease? Handheld Doppler and ultrasound for ABPI, again, you do for arterial disease, or VTE, duplex ultrasound, similar. And the full blood count using these LFTs, that's what I was thinking if you were considering whether it's infected or not. Okay. Any questions about that before we move on to the next question? I'm gonna guess no.
Should we move on and people can ask as they go through? Yeah.
Yeah. Okay.
Oh, so there should be a way to like see the extra info. Oh, sorry.
It should be on your phones. I think it should be on your phones. There'll be an extra way to see info, yeah. So whatever you're using Menti on, ask for the extra info.
We'll send the slides out afterwards as well.
Yeah. And the slides have everything. It's a nightmare getting Menti to do stuff.
So there's 5 seconds left.
Oh wait, it doesn't come up. That's annoying. I'll tell you what. Let's do that again, but I'll post the extra stuff in the chat.
Oh, is it not coming up? Okay.
I don't know why. It comes up on my phone, but not my laptop.
Weird.
Just give me 2 seconds.
Do you want to post it on the chat like before I start the timers? Is that easier? Yeah.
Just give me a second, guys. Sorry, Menti is a nightmare to use, but it's also very convenient. This is question.
I have my slides up, so I can just copy and paste it if you want.
I have your slides up as well.
Okay, fine.
Can you reset the timer by any chance? Is that a thing you can do if you hover on the top?
Is there a way?
If you hover in the bottom left, there should be a way of doing it. Like just.
It's not letting me because they've already voted.
Oh, it's fine. But this was the question. If you want to, it's in the chat. So if you want to have a go, if you want to change your answer, you're allowed to. But it's good that without any other, like, it is good practice. A lot of you went for infective endocarditis, and yeah, a new murmur, usually until proven otherwise, is infective endocarditis. I've just realized the answer's revealed, so there's no point going through this. But yeah, Prina, go for it.
Okay, so with this question, I kind of really wanted to test you on how well you understand the murmurs. So it says that he's a patient in a cardiology clinic and he's already had a mitral valve replacement. And now he's got a new mid to late diastolic murmur. So for those of you that went for infective endocarditis, yes, good. Anyone with a new murmur, think infective endocarditis. But if he has just had a valve replacement, and maybe it was for infective endocarditis, that would have been treated first. So it's really unlikely to have a reason for a valvulopathy, have that replaced, for them to like not check that you don't have endocarditis, and then you've got it again. So that's why, like, good shout, but that wasn't the right answer. So tricuspid regurgitation, you do have a mid to late diastolic murmur. No, you don't. You have a pansystolic murmur with tricuspid regurgitation, which is why that's the wrong answer. Tricuspid stenosis, you would have a mid to late diastolic murmur. But again, he's 64. If it was congenital, they would have picked it up when they replaced his mitral valve. So the two options that I wanted you to debate were basically, is this normal after he's had his mitral valve replaced, or is this his artificial valve failing? So if you've got an artificial valve, when it fails, it basically doesn't do its job, i.e. it allows regurgitation. So that would be a mitral valve regurgitation, which is a pansystolic murmur. And that's not what you're hearing. You're hearing a mid to late diastolic murmur. So that's actually quite normal after surgery to just have some turbulence, a little bit of stenosis and a new valve. And that will happen because it happens in diastole. It happens at the right time. It happens when blood's being pushed from the atria to the ventricles. Does that make sense? Someone put if they're confused in the chat. And Izzy, could you go to the next slide? Sorry.
Yeah, sure.
I think it's worth pointing out that, yeah, also just remember, is like the most important thing to rule out, but the likeliest cause is probably just a benign murmur after replacement. If they were like, which of the following would you absolutely rule out? It's infective endocarditis. Or what's the most important thing to exclude? It's infective endocarditis.
So you don't need to know much about artificial valves, but essentially there's two main types. There's a biological and a metallic. Does anyone know how to tell the difference on examination? So the metallic ones, yeah, exactly. So the metallic ones will click, and sometimes you don't even need a stethoscope. You could just hear it. Exactly. Surgical scars I'd be careful with because sometimes they will have the same ones. But yes, good job. So essentially with artificial valves, if you hear a murmur, ask yourself what that murmur signifies. If it's stenosis, that's fine. If it's regurgitation, that's when it's not working. And then just look for signs like pulmonary edema or left or right side heart failure, which can help confirm that, okay?
Can I just add two things to that?
Yeah.
So one thing I'll add is you need to compare the murmur to what is noted after their operation, because if it's different, that is infective endocarditis until proven otherwise again. Because they should like note it after the operation, be like, this murmur is noted due to the valve replacement. The other thing I was gonna say is important, like the metallic click is something that will come up in OSCEs. In my year 4 OSCE, you could hear the click of the person's heart valve from outside the bay for the OSCE. So you could walk in with a diagnosis. So like, pay attention.
Okay, so moving on to the next question. Should I put it in the chat, the blurb?
Yeah, go for it.
Okay.
There you go. I've done it. Well, it's loading.
There's a corresponding X-ray. I'm going to put like a zoomed in version in case they wanted to have a look. And then I guess, should we start the timer soon?
Give them a...
Yeah, I'll start the timer now.
Oh, interesting. Okay, another split. Fine. Okay, so let's talk about this. What's the diagnosis that everyone's concerned about in this patient? Someone put it in the chat. Yeah, a scaphoid fracture. And with a scaphoid fracture, what's the like eventual bad complication that we're trying to avoid if we don't treat it properly? Yeah, avascular necrosis, exactly. So just like the hip, your scaphoid is one of those bones that has a retrograde blood supply, which means if it fractures, that's altered and it doesn't heal as well, and you get avascular necrosis in the long term. So if we go back to the blurb of this question, it tells you he's a civil servant who obviously hates his boss, Priti Patel. He's punched her. And the signs that give away that it's a scaphoid fracture are, one, the fact that like the injury happened in a punching motion, and two, that he's got tenderness over his anatomical snuff box. So Izzy, if we go on to the next slide.
Yeah.
So your anatomical snuff box is kind of basically where your scaphoid's at. And the way that you can get, I'm going to need my camera for this because it's the only way I can explain it. Can you see me? Yes, no?
Yes.
Yeah, okay, so the way you get a scaphoid fracture is basically anything that causes compression in your like axial plane, so along here, when you've extended your wrist, like hyperextended it. So when you're punching, or if you're at a steering wheel and you have to brake really hard or get into an accident and pressure goes through your hand this way, or if you fell on it, basically. So that's what foosh is, that's falling on an outstretched hand. And they get tenderness, as we said, over the anatomical snuff box, pain when they're gripping, and pain on axial loading. So basically, if you get their thumb and just like push it in, like in, that would hurt. And the only way you can investigate a scaphoid fracture properly, gold standard, is MRI. So an X-ray doesn't rule it out. A repeat X-ray doesn't rule it out. You need an MRI to actually diagnose it. So basically the management is that you treat it as a fracture if they've got the clinical signs, even if then X-ray is normal, so as it was in this question, and then you re-X-ray them in 2 weeks' time. And if they've still got clinical signs, like ongoing pain, or if you can see a fracture, because sometimes it takes a few days for it to come up on an X-ray, then you treat them as if they've got scaphoid fracture. And when you treat them for scaphoid fracture, it's a cast below the elbow, and it's not, so there's a below elbow cast and there's a scaphoid cast, and I was told that there's like a bit of controversy over which one to use, but there's no evidence apparently that the scaphoid cast improves outcomes. So basically just a standard below elbow cast will do. Okay, so hopefully that's explained the answers. Any questions?
Bonus question, sorry, as a bonus question, What fracture do you typically expect to see following a history of someone punching something? So 25-year-old man comes, he's punched a wall and he comes with a pain in a bone. Then it's interesting.
Yeah.
I was thinking maybe Bennett's is another. I'm getting confused now. I was thinking another one. Can anyone else offer any others?
To answer your question, Maddie, no, you can't. This is a completely normal wrist X-ray that I've lifted.
And so that Raja was thinking about the fifth metacarpal or the boxer's fracture, because as you can imagine, if you're hitting something with a closed fist.
Bennett is also from punching. They're both correct. It's just they're kind of the opposite sides of the hand.
Very nice. Well, there you go. Well done, both of you.
I guess to signpost you guys, because I don't think you need to learn sort of every fracture in fourth year, but I would really recommend hips, scaphoid, collies, the ones you hear about most commonly. I would really recommend learning them.
Scaphoid is like scaphoid. They love examining. Just absolutely love it.
Cool. I think it's James next.
Okay. Is the countdown only 15 seconds?
Yeah.
Okay. So
I've
what I'll do is I've
posted
just
the
posted
question in the chat.
Okay, both of us have posted the same question. Oh, with nice designs. I'll let Enish do the posting. So yeah, I will give you like 20 seconds to think it through, and then we'll start the countdown, so you're less frazzled by the 5, 4, 3, 2, 1 thing. This is a bit cheeky because I didn't realise we were doing this term, so I think it might be a question from last term, but it's still good revision.
Rewards commitment.
And if not, it's an interesting learning point anyway. Should we start the countdown now?
Yeah.
Cool. $20 seconds.
10 seconds left.
Oh, a very interesting spread. Here we go. Okay. Maybe I made this question really difficult. Okay, so let's talk parts of the question first before we move on to the next slide. So first of all, can anyone tell me what I mean by HBSS genes? What disease am I referring to? Sickle cell, fantastic. Yes, sickle cell disease, very well done. And so when we think about sickle cell, they are considered immunocompromised or immunosuppressed. No, they're at risk of a certain type of infection. And does anyone know why? It's sickle cell crises affecting a certain part of their body. Ah, well done, Roja. Something to do with the spleen. You're absolutely right. So, as you know, the spleen filters all our blood. And if red blood cells sickle there and continue on sickling over a long period of time, then you'll get basically functional asplenia. So the spleen will shrivel up, it'll infarct, and it won't do its job. So by the age of 2, I think, most sickle cell patients don't have a functioning spleen. So now that we know that you're sort of more at risk because you're lacking a spleen, does anyone know what infections we worry about if you don't have a functioning spleen? What type of infection? Fantastic, Kareem. Yeah, encapsulated organisms. So bacteria with capsules Good suggestion, Roger. But yeah, it's mostly specifically bacteria that have capsules around them, because the spleen's very good at eating up encapsulated organisms. So without a functioning spleen, we're at risk of that. We can move on to the next slide. So there's a really useful mnemonic for you to know which bacteria are encapsulated, and so if there's no functioning spleen, they're sort of ones we worry a bit more about. So it's Shineski's that you've got down there. So strep pneumonia, Haemophilus influenza type B, which isn't that common anymore. Neisseria meningitidis, which is a big one. E. coli. Salmonella, which is really interesting because it also helps us remember in sickle cell patients, if they have osteomyelitis, the most common causative organism of it is not actually Staph aureus, it's Salmonella, and it partly is to do with this. And then group B strep. Can anyone name another disease that gives us functional hyposplenism? I'm thinking about one where they might present with another type of anemia. Celiac, fantastic, well done. Yeah, so celiac disease, you also have a functional hyposplenism. So we have to give them a very important vaccine. Does anyone know which vaccine we specifically offer to them, despite them not being the usual age that we give it at? One-off pneumococcal. So you're almost there, Roger. So it's the pneumococcal vaccine that we give. In most people, so when you're 65 or above, you get a one-off pneumococcal vaccine. And in these populations, I love 5 years. You 5 yearly, yeah. In these populations, when they have functional hyposplenism, we give them every 5 years. So it's taught very much in celiac disease, but it's actually the same case in sickle cell as well. But yes, so lots of learning points from there. Sorry, it was a very mean question. Any questions about that before we move on? Okay, we'll do the same thing again. So if Anush could send a screenshot of the next question, and we'll give you 20 seconds to think about it before we start the timer.
Also, James has helpfully, when you get these slides, James has helpfully put what lectures these slides, these questions relate to. So if you're confused about any of them, you can go back over those as well. I should do that. Maybe I'll do it afterwards. That's a good idea, James. I suck.
Okay, so if we could start the timer now. So this one is an antibiotics one, if I remember correctly. Long question, sorry. Fantastic, well done, team. Oh, what?
Oh wait, did I pick the wrong one?
Yeah, I think.
Yeah.
Oh, sorry.
The people who went for A,
it's our
take
bad.
the moral victory. You've done really well. Well done. Can anyone tell me what the antibiotic I'm referring to is? In our favourite, our Hulk. So yes. What was I going to say about this? Yeah. So with infective endocarditis, you want to give IV antibiotics. You want to have you often give Comox or Benpen, and then you want gram-negative cover. So you typically give gentamicin. And gentamicin is well known to cause nephrotoxic and ototoxic side effects. One of the things that I wanted to put here as a learning point is that the med school know you remember gentamicin as nephrotoxic and ototoxic, so they'll try and rephrase things. So 8 of you weren't caught out here. So instead of ototoxicity, they've written sensory neural hearing loss. And that's just to catch out the people who are rote learning things from past med. So it's really, really good that you're actually sort of breaking things down and understanding what's happening here. Same thing with the previous question where I put HBSS instead of a sickle cell disease. So get used to spotting those and get used to the med school trying to trip you up there. Okay. Before we go on to the next slide, I think it's useful for us to go through the other side effects, because they're all side effects for other antibiotics. So Cholestatic jaundice. There's quite a few that do this, but can anyone give me an antibiotic that will give you cholestasis? Kermox, fantastic. Well done, Roger. Any others? Kermox is a big one, so I'm happy with that. Other ones that can cause it are fusidic acid, flucloxacillin, and there's another one as well. But steroids as well can cause cholestasis, so think about that. Pulmonary fibrosis. Does anyone know what antibiotic causes this? Long-term use. It's a bit more of a rogue one. Very good. So nitrofurantoin is the one I was looking for. Bleomycin, I'm pretty sure, is a chemotherapy. But yes, well done. They are both ones that cause pulmonary fibrosis. Fantastic. Widespread erythematous rash and intense pruritus. No worries. No. You've offered two very good options. Vancomycin, very good. Vancomycin can also cause ototoxicity and nephrotoxicity, but it's not so well associated. And then finally, spontaneous tendon rupture. Cipro, good, very good. Ciprofloxacin, a fluoroquinolone. Well done all. Yes, so if any of that sort of flew over your head, the YouTube on the antibiotics is probably quite a good reference point. Okay, on to my third and final question.
That's the summary.
That's my explanation. Yeah, I tried to colour code things. It didn't work out that well. Last question, if Anush could first.
Also, a quick clue for that previous one. If it's given IV, it's never Cipro. Generally, unless they're unconscious. Because or they have like an unsafe swallow. Because the whole like shebang with Cipro is the fact that it's equally bioavailable orally as IV and is the only oral anti-pseudomonal. So like the rationale behind using it is the fact that it's not IV. Just a general clue.
I'm aware there's 16 people here and we usually have 11 people answering, so I think I'll hang on an extra 10 seconds just so you're slightly less pushed for time.
I apologize in advance if we have any more incorrectly labeled answers. It's just Menti's a nightmare to use.
We try.
The moral victory is more important than the external validation you receive from Menti.
Okay, let's start the countdown.
James is the tired peds reg in like 5 years.
Oh, fantastic. Well done. This was a really difficult question because I know we haven't had these, and maybe you guys have proven that you don't need one. But yes, let's break this question down. So DKA, what electrolyte abnormality are we worried about most and why? Hypokalemia, fantastic. And can anyone offer why we're worried about hypokalemia or what in our management of DKA causes the hypokalemia? Very well done, Roger. Well done, Jordan. Both of you are spot on. So what happens with this population is you get the VVG back and the potassium is normal, and you're like, oh, that's fine, no electrolyte abnormalities. Then you start them on fixed rate insulin, and they suddenly plunge because as well as moving glucose into your cells, it moves potassium in too. So even if they have a normal potassium, you'll be thinking about supplementing their fluids with potassium. It's only when it's hyperkalemia on the BBG where you check with your senior and figure something out. But yeah, so let's talk through the management that this PEDS reg did. They started, they gave a fluid bolus, fantastic. Then they started regular saline and given fixed rate insulin. Does anyone remember the dose of fixed rate insulin we give? This is a useful one to remember because I feel like of the emergencies, doses you should definitely remember. Yes, very good. 0.1 units per kilogram per hour. Fantastic. So you just divide their weight by 10. Oh, well done, all of you. Fantastic. So yeah, you divide their weight by 10. Good. And then, yeah, does anyone know why we start insulin an hour after starting fluids? This is probably more for general interest, but there's a complication of our treatment that we worry about, particularly in children. CPM. What does CPM stand for? Oh, is a complication cerebral? Go on.
It's central pontine myelinolysis, presumably.
I think that's more with rapid shifts of sodium. Correct me if I'm wrong, Anush.
That is,
but the one,
with it, yeah.
The complication. No, don't apologise. Don't worry at all. It's a good one to remember as well because yeah, you're careful when you correct sodium levels. But the complication is cerebral edema, and the jury is currently out on why. People theorise it's blood-brain barrier. People theorise it's rapid shifts in fluid from someone really dehydrated to getting lots of fluids. But the main thing is cerebral edema. Okay.
To be fair, like CPM is like physiologically the exact opposite of cerebral edema. So like it's like if you correct like one thing, if you do it too quickly, you end up in cerebral edema. If you correct the opposite, like sodium issue, then you get central pontine myelinolysis. It's more like a year 5 thing than a year 4 thing. But like we can go over it at some point. It is quite interesting.
Good. And then just to round off the DKA management, at what point would you start them on glucose for fluids, dextrose? So a day later, you can see their glucose is dropping a little bit, below 15. I think it's below 14, but very good, pretty much there. No, don't worry. So less than 14, and then you start them on glucose because you don't want them to have hypos, and then you stop them on the fixed rate insulin when their ketones are either undetectable on urine or less than 0.3 in the blood. Numbers are sometimes useful to remember for the emergencies because you won't have time in real life to look them up. Good. So of these ECG findings, flattened T-waves is the only one that's hyperkalemia. We'll discuss ECGs in the future. Yeah, I tried before the slides got ruined by Menti to put the ECG thing to the thing. But yes, thank you. Well done, all.
Cool. I think it's Divya next.
Yeah. I think if I just realised, like, the first question, did you manage to put the normal ranges on the slide, is he?
No, I actually didn't. So if you post those, that'd be really handy.
Yeah, I'll just copy and paste. One sec.
Sorry, my laptop just fully died. Give me a second.
Oh, it's fine. Oh, I think this is gonna send in a huge text. I don't know. I just sent. Did that even? Oh yeah, that's huge. Sorry about that, but just so everyone can see, the normal ranges for blood gases. You'll need that. So yeah, we can start the first question. Or initially, do you want me to post, or are you posting a screenshot first?
I'll do it as in my laptop returns
okay, yeah.
function.
Yeah, no worries.
Yeah, I think this one would be mean with the countdown.
Yeah, that's what I was thinking.
Like I would really struggle.
I think I've sent
Thank
it
you.
out.
Yeah, that's actually got the normal ranges on as well, I think. Yeah, so if you guys just have a read of that and give you a minute, and then we'll start the countdown.
I'm just having a bad tech day.
I'm always having a bad tech day.
Should we start the countdown?
Yeah.
Yeah, I think that's fine. Yay, well done. So I think most of you got that. So we don't have explanation slides, but I'm just going to talk through. If you guys can just look at the history. So, I mean, first thing is that obviously the pH is raised, so we know that it's an alkalosis straight off the bat. And then if we go down to our other options, the CO2 is low, and obviously CO2 is what causes the pH to become acidic. So if it's low, then we can probably safely say that that's causing the alkalosis. And if we look at the bicarb, that's below range. So with a low bicarb, you'd expect an acidic pH to be reflected. So you know, therefore, it's not caused by metabolic abnormality. And so we've got, but obviously it's only partial compensation because this pH is still out of normal range. So if it was fully compensated, the pH would still be normal at this point. And the base excess is just to show that we have got, it's negative, we've got less bicarb basically. So does anyone know what's probably going on here? What's caused this based on history? Yeah, exactly. Panic attack. They love to try and make you think that it's going to be some like actual, like, I don't know, some functional, like organic thing, but this is quite a common kind of stem to confuse you, is basically someone having like palpitations, feeling really short of breath, and trying to make you think of like cardiac causes or rest causes, but it's actually just a panic attack. So they're breathing really heavily, they're hyperventilating, and yeah, I was going to say peas also could cause this abnormality. They're hyperventilating, so they're blowing off their CO2. The CO2 is low, and that's going to cause an alkalotic pH. So that could also happen if, yeah, like Anish said, like a PE could cause that, a pneumothorax as well. And also just something like if you've excessively mechanically ventilated a patient, you can also cause this, as in your artificially causing them to hyperventilate essentially, and if you do that, then their blood gas can be a bit deranged. So yeah, that's the main thing about that one. We can go on to the next question. Thank you.
Go on, start the time.
Yeah.
Izzy, do you want to start the timer?
Yeah.
Okay, so a bit of a split there. Okay, so if we just first work through, we've been basically told by, given the fact that they've done a well score, that this is a PE that they're suspecting. So if we start from there, why the well score is 6, what are the cut-offs for the well score when we're suspecting PE, and do you know what we do as a result of that cut-off? So when you do the well score, if you've got quite a high clinical suspicion of a PE, and then there's a number that if the well score above a certain number, you do something. If it's below, does anyone know what the number is, or what a well score might dictate that you do?
Roger's gone for 4.
Sorry?
Someone's gone for 4 in the chat.
Nice. Okay, yeah. Oh, sorry, it didn't come up. Yeah, exactly. So I think 2 is for DVT, but for a PE it's 4. So essentially, if your score is 4, if it's above 4, you're basically saying that the P is quite likely, so you're not going to waste time doing a D-dimer because that's probably going to be raised. So you just go straight to the CTPA or the VQ scan. And the most important thing to remember with all of these is that if you're suspecting a PE, you have to treat before you get the results back, because you're saying that you think it is probably that and you're going to rule it out. But in the interim, you need to anticoagulate them. And low molecular weight heparin isn't used anymore. It's actually just DOACs. And it's either apixaban or rivaroxaban, both of them are first line. So in this case, the well score is above 4, so we're going to not do a D-dimer, and we're going to give them anticoagulation in the interim. So we're going to give them apixaban, and we're just going to go to a CTPA. So why might we not want to do a CTPA? Why might we want to do a VQ scan? In what patients? Oh my gosh, loads of answers. Sorry, I have to exit them all, otherwise I can't see it. 1 sec. Renal disease, exactly, and pregnant, yeah. So pregnant because of radiation exposure, and renal function, exactly. So contrast is nephrotoxic, so we want to avoid CTPAs in those situations if someone's got reduced renal function, and they love to just throw that in, and then you just need to be aware that you're going to do a VQ scan because it has less radiation, but otherwise you're going to go for a CTPA most likely. And then just chest x-ray, because you actually are meant to do a chest x-ray on every patient that you're suspecting a PE in. So there's that classical clinical finding on chest x-ray, but what is the other thing that we actually just more likely to, what sign are we more likely to see? Not on a chest x-ray, ECG. What are we more likely to see, sorry? Sinus tachycardia, exactly. That's actually the most common thing. And also just remember that with patients presenting with PE, they can actually have a slight fever, so that sometimes throws people off. Just put that in the stem. But yeah, well done. So this is from, so no, it's fine. So not a D-dimer because her well score is above 4. And obviously the well score is made up of like risk factors for PE. So if you've got a high well score, you're basically saying it's very likely they've got PE. So there's no point wasting time doing a D-dimer. You're just going to go straight to imaging so you can identify it. But if it's below 4, then you do a D-dimer and still anticoagulate in the interim because you're still saying that we think it could be that. So basically above 4, don't do a D-dimer. Below 4, you do want to do a D-dimer, if that makes sense. Yeah, no worries. Yeah, I think that's basically everything about that. We can go on to the next one, Izzy. Or actually, if we post a screenshot, sorry. Also, that all of that stuff for PE, I have like in that session we did on shortness of breath. I think me and James did it. There's I've got all this stuff written there, all the investigations and what the scores mean and management, so you can look back at that. I think it was term 1. Thank you.
Ready?
I think maybe wait a sec because I think Anish just posted it, but we'll give him like 20 seconds and then I think that's probably fine. 20 To be honest, yeah, you can just post it. We're running out of time. Okay, so it was a bit split. So first of all, what do people think is going on here? What is this history suggesting? Alzheimer's, yeah. So an elderly patient, there's global cognitive decline. Yeah, well done. And it's a gradual onset over like a year and a half or 2 years. And they've just, when I say global impairment, so they've got problems with like executive function. So they've got problems planning things, their memory is going, their verbal, they're also verbally impaired as well. They can't remember words for things. So just a quick thing to point out is the fact that you always are only going to start medication for these patients on a specialist will always do this. You're not going to be a GP and you're not going to private it for someone. It will always have to be a neurologist. So basically, just with Alzheimer's, if it's mild or moderate disease, which this is because she's still able to, yeah, sorry, I'll wrap up. Because she's still able to like actually do her daily functioning, she's probably like mild to moderate Alzheimer's. And with that, you always start with monotherapy. So you only do one ACE inhibitor, and it doesn't, ACE inhibitor, acetylcholinesterase inhibitor. And it can be any of donepezil, galantamine, or rivastigmine. And I've just put donepezil as the only one that's a monotherapy there. So you want to put that in. And then you can add memantine if as an add-on, or if it's like very severe Alzheimer's, or if they're kind of resistant or not tolerating the the acetylcholinesterase inhibitors. So just basically, when you're first line starting, it's just unlikely you're going to start 2 concurrently. It wouldn't be the case. So yes, that's it. Very well done, everyone.
Cool. I think it's me next, and I can't actually see what my questions are because I'm sharing my screen. So I guess like Anush will post it, and I will be as confused as you guys are as to which one it is.
Sorry, my laptop's being annoying and keeps bringing pop-ups. These last 2 rounds are a bit more rapid fire, because they're a bit statistical and a bit buzzwordy. So the opposite of what has come before. So you'll get a few questions like this, and you'll get a few and a lot of questions like it'll be a mix of like buzzwordy stuff and more UCL type things in your exam. So these are some of the easier questions you'll get.
Have you posted it?
Yeah.
Cool. Should I go for it?
Oh my god, I sent the slide with the answer because I'm an idiot. Sorry, I have like 500 windows open.
It's okay. I guess people
it's
can.
Fine. You will get this one. Got outed. Rip.
Oh, that is a quick answering.
Yeah.
Nice.
In the chat, can someone explain why that is the correct answer?
So basically, like these could all put your calcium up, but like, why is primary hyperparathyroid the right answer? And Anish will have to like read the answers for me because I can't see them.
Shout out to the 2 people who didn't see the right answer and still went out for the other things. This is the worst explanation for a question ever, but you will get questions like this, so I don't apologize.
Because also, if you had someone in this situation, you would want to rule out a malignancy. Like, it would be negligible to not do that. So this is kind of one of those SBAs that they'll do for you, and you're a bit like, how does this make me better as a doctor?
Yeah. No one has guessed yet. So the answer is basically statistics. So in a 52-year-old with this presentation, the likeliest cause is just primary hyperparathyroidism. You would rule out stuff, but unfortunately the question is most likely. Right, the next question I won't, oh my God, I will not post the answer to, hopefully. Right. Those of you that were here last week will enjoy the answer, will know the answer to this question. Or will quickly open the slides from last week and then know the answer to the question. I always forget this, to be honest.
Also an important one to ask a question on, because the past, last time I checked, the past notes for this is out of date, so people learn it wrong.
For this one?
I think so. Yeah. So I think maybe for this case, no, but when with high INRs, the explanation of past med is out of date.
Yeah, so I had this, if anyone's interested, I did this on my previous presentation just from the BNF, so should be up to date. So basically this woman is actively bleeding, and her INR is above 8, so that's kind of huge warning signs, because her INR realistically should be between 2 and 3 or 3 and 4, depending on the severity of her antiphospholipid. So definitely, like, you've all put stop the warfarin rather than jumping to an OGD. Vitamin K will take hours to work, and you don't really have hours if she's got syncope. That's a very bad sign. So prothrombin concentrate is like the first line, and basically like you only give FFP alongside it or instead of it if you don't have any available, but like when does that ever happen in real life? So yeah, if you look back on the slides, like it's I wrote it out so you can just sort of learn what to do in each situation.
I put it in the chat as well.
Cool, snazzy. Okay. Next one.
It's in the chat.
Cool. Let's go. Oh, and CM means cross match, and GNS means group and save. I was running out of room, really.
The word limit on the character limit on Menti is actually really annoying.
It's so annoying. Ooh, interesting. So I guess this is all about like what you think the underlying pathology is. So this was I was getting at was like that this guy has like a bowel infarct essentially, and so the general surgeons are basically only going to really care about what will affect their operation. And so you've all not sort of fell into the thing of like you've all remembered the group and save and the cross match, because they're going to realistically need, you know, probably 4 units or more in this operation, and that they're going to want to know electrolytes and LFTs because of clotting. But I think the main thing that the reason why 4 is correct is it's got the and I have abbreviated it, so I'm sorry. It has got like coagulation studies in it, so it would be good to know if this basically like what the clotting is in this person, because that's going to have, you know, that's going to decide whether they are fit for that operation there and then, or if they're more likely to deteriorate, you know, from having a laparotomy. But like that's a particularly mean question. Okay, cool. Next one.
It's in the chat. Also, a good learning point: don't unnecessarily order ESR CRP when they won't add anything, because
They'll probably be erased as well. Like they'd be raised.
They're peritonitic. Like if they're peritonitic, you know that ESR and CRP are going to be raised. They won't add anything, so don't order it. I mean, definitely don't do an ESR.
I also made it more difficult to read by mixing up the order, and I think that's something the med school would do. So it's definitely something where like you just assume you know the answer and you mess it up, which we all do. We just, you get to like question 50 and you just stop reading. So yeah, that's like another thing they might do to you.
With those ones, sorry, the thing that like clicked it for me was someone would be like, before you read the options, write down what you would actually do. And then if it's like on there, debate what, like if it's not on there, debate which ones add anything to your management, basically.
Oh, Mark, this is yours. This is yours. If you're there.
Yeah, so is this mine?
Yeah.
Oh, yeah, it is.
Oh. Interesting.
Huh? What? Okay. Does anyone want to justify? Wait, why did it come off Kestrel-Axon and acyclovir is the correct answer?
Oh, because that was what. Yeah, that's a mistake. It's fine.
That's a mistake.
Yeah,
that's a mistake.
Yeah.
So yeah, you guys are very correct in saying Kestrel-Axon. Whoever the four were to put that out. He's not in the age range to give Kestrel-Axon and amoxicillin. Remember last time I spoke about meningitis, I said we give amoxicillin for a specific type of infection, and it's in 3 groups: either the very young, the very old, or pregnant. Anyone wants to tell me what that infection is very quickly? So listeria monocyte, listeria, basically. You're giving it in listeria. So yeah. So it's to cover for listeria. He's 28, highly unlikely he's going to have listeria as the causative organism. So ceftriaxone is the mainstay. Ceftriaxone, 2 grams, BD, IV. Good. What's the next question?
Cool.
Oh no, I just put the answer because the answers are on the slides. Skip this question. The answer is Koenig's. Know your meningitis signs.
Yeah, know your meningitis signs. That would have been a fun one. Anyway, yeah.
You could ask them what the other signs are.
Oh, okay. What's the other meningitis sign very quickly? So it's one of the other that is listed here, and then what is it? So what are you trying to elicit when you're trying to elicit the sign? So Koenig's is one of them. What's the other sign we look for in meningitis or meningism? It is C. Brzezinski's, and Brzezinski's is pain on neck flexion. Yeah. No, it's fine. So yeah, pain on neck flexion. So you ask the patient to touch their chin to their chest, and if they either can't because of pain or they flex their hip when you ask them to touch their chin to their chest. Okay, very good. What's the next question?
Yeah, as James said, remember to take a proper history and examine the patient.
Exactly. You're just eliciting these signs on examination if you have the clinical suspicion of this. It's not going to knock out or it doesn't exclude your diagnosis necessarily. It's just signs that you can elicit on examination that might help confirm the diagnosis a bit more.
Start the countdown. I would expect you all to answer this question using only the last line of the question and the options. And Mark will agree with me in a minute.
I can't even remember what question I wrote. Yeah. Very good, very good. And why is warfarin? Why would you be careful about giving her warfarin? Or sorry, why would you be careful about giving her clarithromycin if she's on warfarin? Yeah, exactly. So is warfarin. It's one. Yeah, exactly. Well, warfarin interacts with everything. So does clarithromycin, effectively, because they're both DYP 450 inhibitors. She might also be on a statin at her age, and that's also contraindicated in, well, not exactly contraindicated, but you want to be careful giving another inhibitor to a patient who's on a statin, because again, it is another inhibitor. It could go up, it could cause rhabdo. In this case, warfarin will likely cause their INR to shoot up. Very good, Jordan. Okay.
Last 3 questions. I think these are mine. Yeah, just remember, if you're going to give them clary and they're on a statin, hold the statin until they finish the clary. That's the so on admission you need to hold the statin. Fine. Just start the timer. So we went over this like 2 weeks ago. And I think this question might rile some people. I think it riled Izzy up a little when I showed her.
Well, it just highlighted how much of diabetes that I have forgotten.
Yeah. Sorry, we're rushing through. You can look over this. The correct answer is current therapy is adequate, because what is the cutoff before you add a second drug? Anyone? 58. Great. 58. Good. Yeah, that's the learning point. Right. Next question. Last 2. Oh, look, it's almost exactly the same question with 2 things changed. This is another UCL move. Ooh, yeah. So there is a split, and this. So sitagliptin is a DPP4 inhibitor, which is safe to use. Pioglitazone, there are no contraindications stated in the question, but you would look at their history. You'd be worried about using that if they had heart failure because it causes fluid retention, or if they've previously had bladder cancer. Gliclazide gives you a risk of hypos, which is a relative contraindication in an elderly person. It can cause issues, but like, you definitely do not want to give an SGLT2 inhibitor like geflosin to an elderly person due to the risk of UTIs, which can cause them to start falling, which is not a good start for when elderly people start falling, they don't stop falling, and that's really dangerous. So geflosin at SGLT2 in someone elderly is the big avoid. If that wasn't an option, then I would say avoid the gliclazide. Exenatide isn't really harmful. You just wouldn't be allowed to use it because it's not licensed for people that don't meet specific criteria. Yeah. Last question, I think.
Yeah.
Last question. Again, this is from a couple of weeks ago. There's only 8 of you left, but good. Ten seconds left. Ooh, 8 of you got in just before. Really good. Yeah. So this patient has atrial fibrillation, valvular atrial fibrillation. This is the only reason, pretty much, in like modern medicine, we still give warfarin over a DOAC. if they have a valvular atrial fibrillation versus like atrial fibrillation of any other cause. Just to go over some of the other options, yeah, apixaban, any non-valvular AF, give them apixaban. Aspirin doesn't help with atrial fibrillation. It prevents platelet plugs forming. So you give it as secondary prevention, not primary prevention. Prasugrel works similar to aspirin. You use it in the context of STEMIs that require PCI now. You always bridge warfarin. The only reason to not bridge warfarin is if they're coming off a DOAC and you're switching them to warfarin. Otherwise, you always bridge them. Otherwise, they will be prothrombotic for the first 5 days, and they're more likely to have a stroke or a DVT or like a load of other like clotting problems. So yeah, really good. That was the last question. Sorry, we wrote a few too many SBAs, but hopefully it was useful. Ooh, good job, Pingu. Whoever there's 2 Pingus. Whoever that Pingu is, again, if you come and find me when I'm at the Royal Free, I will buy you a coffee as a prize. No one took me up on that offer last time, so I don't think anyone's going to take me up on it this time either. Sorry for overrunning, but yeah, we'll post the slides with all the explanations. If you have any questions, I'll stick around for like 5 minutes or so. Just ask them. We did rush through the last few.
Just one quick note. Don't be disheartened if you find